My name is Fabian Bamberg. I'm today's moderator of our 7th webinar entitled Anatomy or Function of Both, Cardiac FFR, CT Perfusion and more. And I welcome all our audiences across the globe to this wonderful series that we have. And I do have the privilege of introducing our today's speaker, who's not only my boss here in Tübingen, he's also the chairman of the Department of Diagnostic Interventional Radiology at the department here at the University of Tübingen in Germany. And Konstantin Nikolaou, he received his medical degree from the Ludwig-Maximilians University in Munich in 2000, where he also became an assistant professor at the Department of Clinical Radiology in Munich. He finalized his PhD thesis on the topic of modern cardiovascular computed tomography techniques in 2007, and in fact he has been one of the pioneers of cardiac imaging throughout the years. And after working as the section chief of CT, PET, CT and MRI in Munich, he became the vice chair in Munich, and that was in 2007. And now he is joining and he is chairing the department here in Tübingen. He is the president of the European Society of Molecular and Functional Imaging and Radiology, it's ESMO4, and the treasurer of the European Society of Cardiac Imaging, our ESCR. He's a member of the research committee of the European Society of Radiology and honorary member of the Greek Society of Radiology. So lots of honors and prizes, and we are very privileged to have him here today. He's just sitting across the building in one of our offices, and we are very much looking forward to your presentation, Konstantin. So please, I think it's get started.
Yeah, thank you, Fabian. I hope everybody is listening and can hear me. It's a pleasure to be here. So you should give me the honors after the talk, because gathering titles doesn't help. So you should decide if you like what we're talking about. But it's very nice to be here, and it's fun to join this webinar sessions. I think it's a good idea to discuss globally on a very modern way. So I hope everybody hears me and can see the screen. I started with the starting screen giving the title of the talk. So what I would like to do with you in the next about 40 minutes, I would say, is give you an overview of where we're going in terms of coronary artery disease imaging, especially in terms of combining information from anatomy and function with a special focus on CT techniques, because I would like to point out that this might be an interesting way to go. And in the end, of course, you can put down some questions, and Fabian will be moderating these, and if I don't know the answer, he will help me, I hope. Great, so let's start. So what's happening here is we're talking about the concepts in coronary artery disease, and I always make the same joke, so to say, with this image, because this young man looks so sporty and so young that I don't think he's a typical candidate, but at least he has some chest pain. So what you would like to do, of course, is one, determine the anatomic variants and morphology of the coronaries, and see if there's a morphological stenosis, and then you want to see if this stenosis has any functional relevance. So you would like to determine whether or how much of the myocardium is indeed ischemic, because finding a stenosis alone, and this is something you will hear throughout the talk, is probably not the best way of making the diagnosis. So this is what you want to have. You want to have the combination of morphology and function. This becomes very obvious. And this looks complicated, but this slide is not complicated. It just tells you that if you compare medical therapy with revascularization, depending on the amount of myocardium that is ischemic, it's not a good idea to do a revascularization if only small amounts of your myocardium are ischemic, because then the people in the revascularization group have even a higher cardiac death rate than the guys in the medical therapy group who have very low cardiac death rates. Only if the volume of ischemic myocardium, or the percentage of ischemic myocardium, goes beyond 10% or beyond 20%, so if larger amounts of your myocardium are indeed ischemic, then the patients start to profit from the revascularization, and the death rates are lower in the revascularization groups. So this shows you, and this is already old knowledge, that you need the proof of a significant amount of myocardium that is ischemic before you make this choice of therapy. This is one thing. So obviously, in a perfect world, you would like to have the one-stop shop or the Swiss knife in cardiac imaging, in the optimal case without any radiation. But maybe we don't have this yet. Of course, sometimes you see wonderful MR angios, and this is an MR, magnetic resonance angio of the coronaries. This is the aorta, this is the right coronary, and you see stenosis here. And then indeed you also already see here a perfusion defect in the RCA territory, the inferior wall. This is the stress image, this is the stress, and this is the rest image, and there's no defect at rest, but there is a perfusion defect at stress. So in a perfect world, this would work out nicely, but the problem is that typically MR doesn't make the nice angios, and others can do much better. Let's look at CT or SPECT CT, where you can get morphological imaging or even morphologic and functional imaging in the same investigation. So the reality is that these modalities still are looking for the right place in the diagnostic workup of coronary artery disease. But again, before any symptoms occur, before you have any typical ECG changes or functional changes, you would see very early on perfusion abnormalities. So it would be very nice to have an easy and fast scan of perfusion in your diagnostic workup. And the bad news is that CT angio, coronary angio alone, is not performing so nicely. If you look at this graph here, and on the left hand you see the FFR, the functional flow reserve, what you would like to have is, of course, if CT shows a non-significant stenosis, then the FFR values are normal, which means above 0.8 or above 0.75. Here, CT is performing very nicely. If you don't see significant disease, you can exclude disease rather safely, which explains the high negative predictive value of CT. If CT is normal or non-significant, you are right. Typically, you exclude patients from having a disease. The problem is, if you say, oh, there is significant disease, and you correlate this with a functional flow reserve, these diagnoses are correct. So positive disease in CT and significantly reduced FFR. However, these diagnoses are not correct. Significant disease in CT, but the functional relevance of this stenosis is limited because the FFR is still normal. So you think that you see a stenosis that is significant, but many of them are not significant, which then explains the very low specificity of CT. So you call people sick who are not sick. The good news is that angio has the same problem. These are the correct diagnoses in angio, and also angio, invasive coronary angiography, would make false positive diagnosis here. So this shows you that both CT angio and angiography have the same problem with morphologic assessment of the stenosis because they do many false positive diagnoses having a low positive predictive value and a low specificity. Okay, so that's fair. Both are not perfect. And we know this, of course, from the FAME trial, who looked at the guiding only interventions with stenosis who are functionally relevant in catheter angiography, and they could show that, this is of course very famous paper, they could show that if you only stent those patients or balloon angioplasty, those patients who have a significant FFR reduced, then the outcome is better as compared to if you just look at morphological stenosis, then the outcome is worse. And also, if you compare the FFR-guided PCI, percutaneous coronary intervention, to a medical therapy, you were doing much better on the long run. In the first days, because of course there's potential complications, there is a little increase in risk for the PCI group, but on the long run there's a significant improvement using PCI, which is FFR guided. So only PCI those patients who have a significant flow restricting stenosis according to FFR.